We have all the speakers come to the podium so we can duke it out. While they're doing that, there was a question about the costs of bioduct exploration and such. Can we go to slide 54 from my intro thing, and I'll just do that while people are coming up here. Our success rate, this was back in, I think it was in the mid-90s, success rate was about 97% from common duct exploration after about close to 400. Now, with over 500, the success rate is similar. It's about 98, 99%. But obviously, that takes some time to accumulate that. This is not working. I'll go forward. So the cost is in here somewhere. Are we able to advance that? Not getting it. Well, anyhow, maybe we can go to the next question. As it turns out, the reimbursement rates for common duct exploration laparoscopically have improved, and actually, at least in our area, the Medicare rates are actually much better than any of the carriers. So I guess we're not. Here we go. So in the next, okay. If you look at the relative value units here on the far left, 47564 is common duct exploration laparoscopically as compared with lap chole without cholangiograms, and this is with cholangiograms. And if you look at past that. So we look at imaging charges for workup of the patient. Endoscopic ultrasound seems to have the highest imaging charges, MRCP a little bit less, CT of the abdomen sort of mid-range, and ultrasound at the least amount. And then in terms of what we get reimbursed in theory from the various carriers and Medicare, the yellow lines are lap chole with cholangiograms, the brown lines are common duct exploration. You can see they pay a little bit more. The other carriers aren't paying that much more than lap chole. So I hope you all don't take that as another reason not to do common duct exploration, but I hope after you leave here today that you at least are going to not be quite as reticent to address it. So I'll turn this over to Dr. Duncan at this point for some questions.
Well, maybe you can, I don't know how you want, if you want to stay there, Joe, but so just so everyone knows, you're open to ask questions, walk up to the mic, and we'll entertain questions from the audience. We have a number of questions that have been texted to us throughout this session, and so I'll kind of go through some of those and try to address as many of the topics as possible. One topic that I think is a good question was the learning curve on intraoperative cholangiography. I think many of the panelists, myself included, said that we do this routinely. If it's something that you're trying to learn, I'd love to get an opinion from the group. I think it's a good question on what do you think the learning curve is for intraoperative cholangiography? Maybe we'll start with you.
Well, I think in a completely elective, easy case, probably doing somewhere between 10 and 20 on an easy elective gallbladder without anatomic abnormalities. But when you're starting to do them, when you really need them on a gangrenous gallbladder and other, then it could be up to 40.
So the time you want to learn is on the easy cases. Take 10 or 15 minutes, and at least with the technique that I prefer, the percutaneous 14-gauge IV catheter, and drop the catheter into the cystic duct, that only takes a few minutes to do the whole thing, especially if you let the radiology people know that have the C-arm there, have it all draped out, spend that time doing it. If you can't do it, then you just back out. But that's the time to check, not 6 o'clock Friday afternoon when you got a gangrenous gallbladder.
The literature says that the learning curve for lap chole, straightforward lap chole, is around 30 cases, and my guess is that so I think that's a good comment at about 30 cases for doing routine cholangiography, but you don't want to be rehearsing, you don't want to be in your learning curve when you're doing those difficult ones. Question at the front microphone.
Hi, I'm Daniel from Mexico City, and I wanted to ask you, sometimes whenever you have common bile duct stones and the patients do, well, or the surgeon or the staff, they take the patient to the ERCP, right? they take out the stones. The patient is still in hospital and is programmed for an elective cholecystectomy. And there's an issue regarding the timing from doing the ERCP and then going for a cholecystectomy. And I have recently some patients that gone for ERCP, apparently being cleared of all the common bile duct stones. And while I'm in the OR, I see a lot of common bile duct stones that start coming out from the gallbladder. So I wanted to see what's your experience in that, if you have encountered that, and if you do intraoperative cholangiogram, knowing that you already have an ERCP beforehand.
So maybe to summarize that question, you're talking about the risk of having choledocholithiasis after an ERCP was done and the duct was cleared. So there are kind of a couple of things in there. One is, what's the appropriate interval between the ERCP and taking the gallbladder out? And two is, should I do a cholangiogram even though they had an ERCP with, so comments on that from the panel. Maybe Ben, we'll start with you since you are our ERCP guy, and it looks like Marty has something to say as well.
Sure. So I think the best information we have is just going to be based on ERC clearance rates and reliable endoscopists. And we would expect that, again, to be upwards of 80, 90% or so. All that being said, certainly the situation you mentioned does happen. I don't think we have a great handle on the precise timing of when we would, in general, recommend, a laparoscopic cholecystectomy. I think most of us in our practice, if they're an inpatient, you'd probably want to do the the cholecystectomy before they go home. It wouldn't be unreasonable, if they wanted to go home, they live locally, you scheduled it in a couple of days. I think that's pretty reasonable if your confidence in ERCP clearance rate is high. And I would urge you, look at the images, talk to your endoscopist. As surgeons, we all know, some cases we feel really good about, some cases we kind of not so feel good about. I think it's worth getting that information to kind of help with the decision making.
But Ben, I think the question is, are they going to get more stones falling down there? You did a great job. You got the stones out. Everything looks good. What's the appropriate timing to get that patient in the operating room? What's the risk of stones dropping in there?
Yeah, so I think the best experience we have with that specific question is looking at our acute biliary pancreatitis experience. We know that in general that waiting past 6 weeks is probably not fortuitous, and so we would therefore assume that in the practice of acute biliary pancreatitis, where it'd be reasonable to perform a cholecystectomy, that should be done before they go home at that discharge. I think that's kind of the best guideline we have for that. The other thing I would mention is that these are typically small stones, and if there's a large stone burden inside the gallbladder itself, at the time of cholecystectomy, if you have a pretty widely patent cystic duct, you can dislodge those stones and send them down the common bile duct as well.
Practical point of view, yesterday I got 2 phone calls from the ERCP lab asking me to do a lap chole yesterday. I said I'd be glad to put it on my schedule for Monday. They said, well, no, thank you. We'll find another surgeon. So I think if you can't respond pretty quickly, you may very well, at least in my environment, lose that case.
Certainly the sooner the better. And then what about cholangiography? ERCP cleared? Go ahead, Ed.
Yeah, just before we go to the cholangiography, it has to do with should you wait until you know the patient doesn't have pancreatitis or a complication from ERCP? In other words, if they did it at 7:30 in the morning, would you put it on the same day at the end of your lineup? Or would you wait till the next day when you know you may not get blamed for their complication? Or your own if you did the ERCP?
Just checking amylase pre-op.
So would you put it at the end of the day, or would you wait till the next morning?
I'd do it as soon as I had a chance to do it. And if that's the end of the day or the next day, I would do it. And a cholangiogram doesn't take that long to do. So I've personally seen stones after a perfect ERCP and stone extraction. I've seen stones in the common duct. And if you look at, okay, we're going to take the cost of a cholangiogram during a lap chole versus a possible return to the OR for another ERC, the cost difference is tremendous there.
Yeah. So you usually do it?
I would do cholangiogram on all of them.
I would say that my preference, if they've had a preoperative ERCP, is to wait until the following day to make sure that they recover. I don't follow amylase. That will be falsely too sensitive. I go on clinical parameters alone, and if they look clinically fine by the next day, then
I mean, logistically, the next day is the easiest for you, and if there's a problem with the ERCP, you're going to get a clue about that overnight. So that really makes most sense. If you look at some of the textbooks, a previous ERCP is almost an indication for cholangiography. I think if you look in practice, if they really have a high reliability, they think everything went well, there wasn't very many stones, I would not repeat the cholangiogram.
So another question here was for transductal exploration, where do you make your colodocotomy?
Well, you'd like to make it as close to the duodenum as possible, because you might be doing a colodoco-duodenal anastomosis for drainage. And that also prevents you from making a difficult closure in the common hepatic duct. As you know, sometimes it's hard to see if you have a cystic duct that's really entering low, or a common wall with a cystic duct, common duct. So in general, you want to make it as low to the duodenum as is safe and comfortable. Don't go, challenging yourself or, going through extra maneuvers to get it down very low.
I don't tend to go quite that low. I go at least 2 centimeters distal to the bifurcation of the ducts, but I try to make it a little bit above that, because sometimes if you got a duodenum that's full of air, it can obscure your ability to sew that T-tube in or close the common choledocotomy. But I think that's just a matter of personal preference.
And just to review the orientation of that ductotomy?
Well, vertical, but if you have a 2.5, 4, 3 centimeter, then I'll make it transverse.
But in general, we do it vertical to not interrupt the blood supply in the duct. Question in the back microphone.
Ayub Khan from UK. Question to Prof. Philip and to Joseph Patelin. Very interesting talk, Prof. Really enjoyed that. I'm just a bit intrigued that you said that when you do hot gallbladders or difficult gallbladders, you have a time limit when you say that you will do a damage control cholecystectomy and start somewhere in the body and dissect upwards. Is it purely time limited factor, or you will see whether the anatomy is difficult and you take it halfway up? Secondly is that I noticed that you have a bit of a difference between Joseph Peterlin, is that you don't do Roux-en-Y in those sort of situation and just close the Hartmann's pouch.
So I didn't understand the question. The first question is what?
First question is about timing of not dissecting the posterior window and going
The posterior what? I'm sorry.
posterior window or critical window, that's what you call here?
Brian, Ed had said that he was going to transect transversely if he didn't achieve isolation of the artery in 4 minutes, and he's asking if it's purely by a time limit or if there's some clinical factors. And then the second question was the business about sewing that distal gallbladder closed as opposed to bringing a Roux limb up to it.
Exactly.
So, yeah, we've, it depends on the resident or the fellow in training, how long we let them try to find the cystic artery up on the fundus of the gallbladder, not in the hilum. Generally, it's an amazingly reproducible time limit, so there's no point in wasting time. I'm not going to see it. And then the issue of there's nothing wrong with doing a Roux-en-Y, but you don't have to. And there is one good report in the literature showing the long-term outcome is equivalent. So if you do this technique and you have, in fact, most of the time you won't have a colodocal cholecystectomy fistula, and it still makes it a safer cholecystectomy and a more efficient one time-wise. But if you do have it, then you're in the wonderful situation of not having to do a Roux-en-Y, and you still have an excellent outcome. But I don't, you saw me trim it down. I don't leave like 3 or 4 centimeters of gallbladder. I just trim it down to about 1.5 centimeters, 2 centimeters, just so I can sew it over the gum and duct.
I think we have time for one more question. One more question via, and
Hi, thanks all. My name is Yusuf. I'm from Bahrain. I have two questions. The first one, if you have a patient who has impacted the stone in the bulavator and they could not cannulate by an ERCP preoperatively, and you could not bypass your catheter to basket it or whatever, so what's your next step? It's a size of 2 to 3 centimeters. So what's your next step from your experience? The second question for me, how safe it is to use a needle in inflamed area it may disrupt the CBD. I mean the needle for cholangiogram.
So the first question was about an impacted stone, and the second one was for using the needle. The needle is a great idea. You use a 25 gauge butterfly. You can go into the common hepatic duct. Even if you get into the vein, you can put some tamponade on that, and that's okay. For a distal stone, it's more difficult. I usually try to break it up. Eddie can
Just a
talk
comment for that needle. The needle used in inflamed area, it may disrupt more than the needle tract itself. Disrupt the CBD. That's my opinion about it. So, what about the
I
others?
didn't understand. I'm sorry, I didn't understand what.
If you use a needle for cholangiogram
Right.
in an inflamed area, it will not only be the puncture that you do it, it may go beyond it. So the tear in the CBD, it may not be controllable. It will not be a linear one. It may go transverse, and so on. So it will be a
Well,
safer.
I think if you had tremendous inflammation in the portal region, and I'm guessing maybe from pancreatitis, because I can't imagine that even with severe acute cholecystitis that's down by the duct just above the duodenum, it's going to be terribly inflamed. You're probably, surgery may not be the best approach for that particular anatomical area. That might be an endoscopic approach in that patient. But I think that if you have even an acutely inflamed gallbladder, my experience at least has been that in the portal region, the inflammation doesn't usually extend tremendously, and you can needle it safely. I've never seen tissue tear or become lacerated by using a butterfly approach.
And the impacted stone, you try to break it up, Joe, you said?
I usually try to break it up with some mechanical force. We used to have an hydraulic lithotripter, but the hospital got rid of it. So anyhow, those can be difficult cases no matter how you approach it. We're limited on time right now. We all have to get to the Carl Storrs lecture. I want to thank everybody for being here, and I'm sure that everybody on the panel would be happy to answer your questions anytime you see us during the rest of the meeting, and certainly this afternoon during the course. So don't hesitate to come up to any of the speakers to ask them a question. They're more than willing to give you their opinion or tips on how to do some things. Thank you very much for being here.